So welcome everyone to this Med Crash course session on dermatology taught by Dr. Nazifa. So if you look on the top right hand corner of the slide, that's a link to our Instagram page. So then if you give us a follow, and then you'll see all our upcoming events. And on the bottom left hand side, that's just our email address. So if you have any questions about the session today or just anything in general you want to know, feel free to get in touch with us and we'll try and reply as soon as we can. And then on the next slide, this is a link to the polls for today. So if you scan the QR code, it'll take you to our kind of VBox polls. So as you go through, you can vote on the questions. So I'll give you a minute just to do that, and I'll post it in the chat as well, just for people who are struggling. I reckon it's probably enough time, but I'll post it in the chat as well.
Yeah.
Yeah, feel free to get started.
Okay, well, hello everyone, good evening. So yeah, my name is Nazifa, and today I'm going to be talking to you guys about some stuff in dermatology. So I've got two sessions on dermatology. Today's session, I'm going to start off by just talking through some terminology, and we'll go through sort of a generic structure that you can use when trying to describe certain lesions or rashes. And not only is that super useful in your exams and in OSCEs, because you might get a station where they might ask you to sort of describe a rash to another clinician or something like that. But of course, in real life as well, it's super useful to have a kind of a basic structure in mind if you ever need to refer someone over. And then we're going to be going through some other skin conditions, things like acne, eczema, psoriasis. And then for part two, which will be, I think, in next month or so, we'll go through emergency dermatological cases and a few other conditions. But for now, just starting off, so terminology. So as I mentioned, terminology and how you describe rashes can be really important. Often, for example, if you are making a referral to and you're speaking to someone from dermatology, that will be it might have to be through the phone, and they might not have pictures on hand where they can see what it is that you're describing. And so often, you know, the advice that you receive might be just as good as the kind of description that you're given. And sometimes it can be a little bit confusing on, you know, how do you describe this red blur of a thing on someone's back, for example. So I just thought it might be a good idea just to go through a few basic terminology and general structure. So obviously you might want to start off with where exactly the lesion is that you're describing. So the site of the lesion, and then the distribution. And the distribution of the lesion might be about sort of where it's spreading. And of course that can be difficult, you know, if you might not know where the origin of the lesion started from, but it might be more predominantly in the back, for example, and you might spread down the arms. But distribution is also important. Say, for example, if you notice it's in certain areas over others. So, for example, in eczema, you might find that the lesions tend to be in your flexor areas of your body, so the insides of your elbows. Whereas psoriasis, these patches tend to be more on your extensor surfaces, so like the back of your elbows. And so that's where describing the distribution can also be quite important, because it gives you a better idea of what that lesion might be. And then the shape of the lesion. So you might hear terms like macula, a macular-papular rash, a nodule. So in essence, the next slide, I'm going to go through this in a little bit more detail. But essentially what these terms mean, so a macule is a flat lesion less than 1 centimeter. A papule is a raised solid lesion less than 1 centimeter. And a nodule is also a raised lesion, but it's more than 1 centimeter, meaning in sort of diameter. And these nodules or papules tend to be quite firm in sort of their consistency. And that is different to vesicles or pustules, which are also raised lesions, but they're not solid. So vesicles, they contain sort of fluid like substances, and pustules will contain pus. A vesicle, just as a side note, is essentially a type of blister. So just imagine a blister that's small. Of course, color is very important. So if it's red, if it's pigmented, if it's got areas of discoloration within the lesion itself, and that's really important, particularly in skin cancers, which is something that we'll be going over. And then you might want to describe the boundary of the lesion. So is it a very regular defined boundary where you can say, you know, it's a circle and you can clearly see it, or is it quite irregular? Is the surface of the lesion, you know, solid, or as I mentioned, is it vesicular? Has it got pus in it? Or the surface might also be quite crusty or dry, and again, that can give you a good idea of what the lesion could be. And of course, if there's one lesion or if there's multiple of them. Just going through the types of lesions. So as I mentioned, there's sort of macules and papules, because I always found this quite confusing when I was in med school when people describe this stuff. So this is kind of just a graphic of what I'm talking about. So a macule, as I mentioned, is a flat lesion that tends to be less than 1 centimeter. Papules are raised. Vesicles are a type of blister. So it's a raised lesion as well that contains fluid-like substances. And then you've got your patches that are flat but more than 1 centimeter. Nodules, as I mentioned, raised lesions that are more than 1 centimeter. And then you've got these plaques that are essentially, I like to see them as larger versions of patches. So, but they're raised. So I should actually say larger versions of nodules. And plaques you'll see in psoriasis. So these kind of raised like lesions that kind of can be across a large area. I would want to say that don't worry about sort of the less than 1 centimeter or more than 1 centimeter. I think in general, if you hear the words macule or patch, think of flat lesions. If you hear papules and nodules, think of something that is raised, like a bump in your skin, that's solid. And with things like vesicles and bullae, just think of blisters. Don't worry so much about if it's less than 1 centimeter, more than 1 centimeter. It's just giving you an idea of whether this lesion is flat or whether it's raised. So I thought I would give you guys just 1 minute to try and see if you can name what these lesions are. So whether it's a macule, a papule, or vesicle. So I'll give you guys a minute now, actually, just to go through that, and then we'll go through all the pictures. It's not an SBA, but maybe if you've got a sort of some paper, you can see if you can label these lesions. Oh, yeah. So, number one is a macule. So you can see it's quite, I appreciate that through the screen, it can be quite difficult to see if something is raised or not. But I think one is quite obviously a flat lesion, and it's, like I said, you're not going to really be able to know if it's more or less than 1 centimeter. But let's just say for the sake of it, it's less than 1 centimeter. So you could say that that's a macule. Number two is larger. It is flat, but it seems to be more than 1 centimeter. So you can call this a patch. Number three, you can see these are raised solid lesions. There's not obvious fluid within these lesions. So I would describe this as being a papule. Four, yeah, you can see that's raised. And again, you can see that's solid. So this one, and it looks like it could be more than 1 centimeter. Again, I appreciate you won't be able to see this through the screen. But this you could say is a nodule. Number five, now here you can see what I mean by vesicle. So these are fluid-filled like raised lesions. They're not obviously pussy, otherwise they would be pustules. So you could say that these are what you would describe as vesicles, so a form of a blister. And number six is bullae. So these are, again, blisters that are larger than 1 centimeter, and therefore you could describe this as being bullae. Now, number 7 and 8. Number 7 is what we call petechiae. And petechiae, and number 8 is called, what is number 8 again? Purpura, sorry. And number 9 is ecchymosis. Now, why I say all of these together is because essentially what 7, 8, and 9 are is when your blood vessels sort of break and you get this bleeding coming up into the surface of your skin. And they're essentially just different sizes. So they're the same thing, it's just different sizes and hence named different things. So 7 petechiae, 8 purpura, and 9 is ecchymosis. And I just gave sort of another picture showing you, what these lesions exactly look like. And why it's really important, particularly with purpura or petechiae, you might have heard of the phrase a macular a non-blanching purpuric rash. And if you've done your peds, you might have heard this term particularly. And it's really important if you see someone with these kind of skin lesions that you press on it to see if they blanch or not. Because a non-blanching purpuric rash, for example, is an indicator of a meningococcal disease. And so that is a medical emergency. And also things like ecchymosis and petechiae, they are, as well as purpura, the kind of bleeding in the skin that is indicative of other conditions, sort of thrombocytopenic conditions, blood clotting disorders, and a whole bunch of other stuff. So essentially, when you look at this, it's important to be aware of what this is and what it could mean. In general, though, my advice when you're describing skin conditions, don't think about it too deeply. If you don't know whether it's a macula or a papule, don't worry about that. You can simply say whether it looks flat or whether it looks raised, and you should be able to know that from seeing it. And then basic things about where it is, roughly, whether it's the kind of if it's got anything obvious on the surface of the lesion, like if it's crusty, if it's bleeding, if it's ulcerating. So essentially just describe whatever you can see. Don't worry too much about the exact terminology if you can't remember it for things around macules, papules, and nodules. Having said that, I thought it'd be good if we could go through maybe describing some rashes. I'm going to give you guys, say, like a minute, 30 seconds to 45 seconds describing this rash. Maybe if you have it on a piece of paper, you can note down how you think you would describe this rash. Say if I was an examiner, or if you were trying to refer a patient over to me and I asked you, what are you looking at? Think about how you would describe it. So I'll give you guys a bit of time. And again, I appreciate that it can be very difficult to see if it's raised or not. But let's say, for example, these lesions are raised. So how you could describe this is you might want to say, so what I can see here are multiple papules of varying sizes, but obvious regular borders and discrete in nature, spread across the back of this individual. I say it's symmetrically distributed. It's not exactly symmetrically, but relatively so, and it's spread across the whole back. It seems to be erythematous in nature, seems to be red. And as I mentioned, each papule has a defined, distinct border and relatively regular. Now, what this rash is, you're not going to know, obviously, whether it's itchy or not, unless the patient tells you. But what you call this rash is a pruritic papular eruption. And this is quite indicative of, or you might often see in individuals with HIV. And sometimes individuals who present for the first time with HIV will have this pruritic papular eruption. And again, it can typically be in your, you can find it in your backs, you can find it in your hands, sort of the extremities of your body. So that's what this rash is. Again, I'm going to give you a minute to describe this lesion that's found on the neck. Okay, so how you might want to describe this is a erythematous nodule with a well-defined boundary and a regular surfacing, with a regular surface. You can see on the surface of this nodule, there's some crusting, yellow crusting, as well as some erosions, talking about these kind of reddish areas. And you might want to mention that it looks like it could be bleeding as well on the surface of this nodule. And what this lesion is describing is a squamous cell carcinoma, or squamous cell carcinoma, however you want to say that. And that brings us on very nicely to our first topic within dermatology that we're just going to be talking about, which is malignant lesions of the skin. Before I go into the different types, just a note about skin tone. So this is the Fitzpatrick scale, and it's a scale that's used to define, I guess, the type of skin tone that you have. And the reason why that's relevant in this case is that if you have a certain skin tone that's more prone to tanning or burning, then you are at higher risk of getting certain malignant skin cancers. But that is not to say that if you are of a darker skin tone, you will not, or it's unlikely you will never get a skin cancer before in your life. And it's really important that we don't ignore people who have darker skin tones when it comes to diagnosing skin cancers, because you can still have a skin cancer even if you're of a darker skin tone. So, you know, sunscreen is important for everyone. And again, why it's important to mention this is that, again, in your when you're trying to, say, for example, refer someone over the phone, you might want to mention the type of skin tone that they have, because again, it kind of helps categorize that risk factor. Obviously, when someone, you know, if you're taking a history from someone, you can see what skin tone they are. But other risk factors you might want to mention when taking a history from someone is things around their UV exposure. So things like, for example, do they go on holiday often? Are they going to areas where there's loads of sun? Were they born in this country, or were they born in an area where there was, you know, where it's sunny and they were exposed to a lot of sun for many years of their lives? Because what you might find with someone is that they've lived in a country, you know, for example, Australia or somewhere, for majority of their life, and they've been around in the sun a lot, and then they come over to the UK, and, you know, a few years down the line, they develop a skin cancer. So it's important to understand sort of their UV exposure. So holidays, where they were born, and also things about, obvious things like, are they using sunbeds or tanning and things like that. So it's important to gauge these kinds of risk factors from an individual. And there are other things around immunosuppression, which can obviously make people more prone to certain skin cancers as well. So, you know, obviously, do they have any cancers, or are they taking any immunosuppressants? So SBA1, I'll give you guys a minute. Let me open up the poll. I hope you guys can answer this question now. So it's a 40-year-old woman who comes to the dermatology clinic because of scab on her scalp. She says that it bled once after she brushed over it with a comb. The patient is an avid sunbather. On physical examination, there is a raised pearly papule with an area of central ulceration and an overlying telangiectasia. Which of the following is the most accurate description of this lesion? So I'll give you guys, say, a minute to answer that. I hope you guys can see. I opened it up, the poll question. This is the first time I'm using this Vivo app.
Let me know if anyone needs the link to the polls again. I've put it in the chat, but if anyone does, then let me know.
Okay, I think we got 3. Okay, let me stop the poll there. So yeah, the majority of you guys got it right. It is D. So what this lesion is describing is a basal cell carcinoma. So this raised pearly papule with central ulceration and overlying telangiectasia. So that's like screams basal cell carcinoma, particularly this raisy pearly papule. And with basal cell carcinoma, you're right, it rarely ever metastasizes. The thing is, with it though, if you see someone with a basal cell carcinoma, it is I don't know if it tends to be defined as a benign skin condition, but you definitely don't want to just leave it there, meaning that you would want to consider a dermatological referral with someone. It doesn't have to be under a 2-week wait pathway, but if someone has a basal cell carcinoma, you would want to consider referring them to dermatology, and you might also want to consider a biopsy of the basal cell carcinoma, particularly if in a GP setting, because sometimes it can be, in real life, these skin conditions can be quite difficult to decide whether it is benign or not, and you don't want to necessarily take that risk. But the good thing with basal cell carcinoma, it almost never metastasizes. And that is quite different in comparison to a melanoma. And a melanoma is what C and E is talking about. So melanomas do frequently metastasize, and the depth of the invasion predicts its risk of metastases, and also it can give us an indication of an individual's mortality rate, and that's known as the Breslow's thickness, and we'll be talking about that a little bit later on. But luckily, it's not as common in, say, as some of the other skin cancers, which is good to know. A is referring to squamous cell carcinoma, and often you will find with squamous cell carcinomas is that they might appear as an actinic keratinosis, firstly, sort of a pre-malignant, in its pre-malignant stage, that then develops into a squamous cell carcinoma, and then we'll go into that in a little bit as well. But firstly, with basal cell carcinoma, so this is what I mean by the sort of pearly papule border, with this telangiectasia in the center of the border, and sometimes that you will find that this central area might ulcerate, it might have this kind of crater-like look. But when you see this pearly papule border, just think basal cell carcinoma. And in terms of what you would do for treatment-wise, so there are, as I mentioned, options of excision. Mohs microsurgery is a type of excision method, which is you would tend to do in, say, for example, more delicate areas. If the lesion is in more delicate area of body, say, for example, around your eye. And essentially with Mohs microsurgery, it's just a kind of a more careful way of excising a lesion. Because like I said, the lesion might be around your eye, which is obviously quite a delicate area. There are certain creams that you can use, imiquimod cream or 5-fluorouracil cream, but I don't think they use that necessarily as much. And you could do radiotherapy potentially as adjunct. But the main thing is, if you see a basal cell carcinoma, you might want to consider in GP land for a dermatology referral. I would probably do it. Doesn't need to be under the 2-week wait pathway, and you might want to also consider biopsy. Now, a squamous cell carcinoma. So you might hear the phrase Bowen's disease. So that is a form of squamous cell carcinoma that is non-invasive. So it's in situ, meaning it hasn't invaded into the epidermis of the skin layer. So that is another term you might hear in reference to a squamous cell carcinoma. So you have your Bowen's disease, or your in situ carcinoma, and then it can develop into something that is invasive, an invasive form of squamous cell carcinoma. But luckily that rarely happens. And with squamous cell carcinoma, again, risk factors, so excessive UV light, it's really important, particularly when you're taking a dermatological history, that you are asking people about their exposure to UV light. immunosuppression. So I remember in past med, the question that always came up was someone has a renal transplant and they develop like a skin lesion and the cancer ends up being squamous cell carcinoma, because immunosuppression, like I said, is a risk factor for skin cancers. And marginal ulcers are a type of ulcers that arise in areas where there might be scars or long-standing injuries or chronic wounds, and these can also develop into squamous cell carcinomas. And what you might see in the history of it is that you will have these lesions that tend to be in sun-exposed areas. They tend to be quite rapidly growing. They might bleed, and they will often be painful. And you would treat, again, when you see a squamous cell carcinoma, unlike with basal cell carcinoma, you do want to refer under a 2-week wait pathway to dermatology, so because you're querying a malignancy. And you can treat, again, with surgery, with biopsy, but often also you can start off by giving creams, and more so in squamous cell carcinoma than basal cell. So creams, as I mentioned previously, 5-fluorouracil or imiquimod cream. And like I said, you need to refer under a 2-week wait pathway. Now, why the history of a squamous cell carcinoma is important is that you would want to differentiate it with an actinic keratosis. Actinic keratosis is a pre-malignant stage to a squamous cell carcinoma. And actually, I mean, if you look at the images of this in comparison to the image of a squamous cell carcinoma, they're quite hard to differentiate. But this is where the history becomes really important, because with actinic keratinosis, they don't tend to be symptomatic, so they don't tend to be painful or bleed. But if someone comes along with a lesion like this and says, oh, doctor, you know, it's growing quite quickly, it's starting to hurt a bit, I noticed a bit of bleeding, then your alarm bells should be ringing, because you might be thinking, has this transformed into a squamous cell carcinoma? And if there is any sort of, if you have any kind of concerns, always 2-week wait it. Meaning refer under a 2-week wait pathway. Again, the treatment for actinic keratosis is these creams, so the 5-fluorouracil and imiquimod cream. And you might want to give some local sort of anesthetic creams that you can get to help if it is painful. Actually, you shouldn't get that with actinic keratosis. You can do that with squamous cell carcinoma, but you can get topical local anesthetics that you can also give people if they're finding these lesions to be quite painful or irritating. Keratocanthoma, I just thought I would show because it looks like it's really scary, but it's actually a benign lesion. It comes from a hair follicle. Actually, it starts off as a hair follicle that ends up growing like this, and it will actually disappear in 3 months. But of course, if you see someone with a lesion like this, you would probably want to biopsy anyway, just to make sure that you don't have a squamous cell carcinoma. But yeah, sometimes you might come across this in your SBAs or in past med at least. Now, the last skin cancer I want to talk about was melanomas. And there are different forms of melanomas. So you have your lentigo malignant melanoma, which is essentially a type of melanoma which you notice more in exposed areas, and it tends to be in situ, meaning it hasn't invaded into the epidermis. You then have your superficial spreading melanomas and your nodular melanomas, and these are invasive forms of melanomas. Superficial spreading, what that means is that it's spread more horizontally, in terms of the invasion of the melanoma is more horizontal in its pathway, whereas a nodular melanoma is more vertical in its growth, hence nodule, so it's raised lesion. And an acral lentiginous melanoma, acral means peripheral parts of your body, so your toes, your fingers, the soles of your feet. These are melanomas that are found in the peripheries of your body. And what's important about this type of melanoma is that it's not found usually in sun-exposed areas, because how much is the sole of your feet, catching sun's rays? But you do also tend to find this melanoma in people with dark skin tones. And so that's really important to note. I just wanted to show you a picture of a subungual melanoma. So this is a melanoma in someone's fingernails, and it's a type of acral melanoma. And again, like I mentioned, you tend to find these kind of melanomas in people of darker skin tones. Now, remember how I first started off with a kind of a few terms on how you can describe certain skin conditions. With melanomas, there's actually a separate structure in which you can describe a skin lesion or a melanoma, and that's this ABCDE approach. And so number one, you might want to be describing whether the mole or the lesion itself is symmetrical or not, because an asymmetrical lesion is more of a alarm bell. The alarm bells kind of ring more with something that's asymmetrical, and it's suggestive of something that is more malignant than others. The border, whether it's regular, whether it's blurry, the color, again, the color is really important, because things that are multicolored tend to be more of a signal towards something that is more malignant than something that is a solid uniform color. The diameter, so the size of the lesion, and its evolution. So have you noticed any changes of this lesion when someone approaches you with it? With this kind of way of describing melanomas, I sometimes also use it with describing skin conditions in general, especially with my OSCEs. I found the ABCDE approach to be quite applicable to most skin lesions, so don't be afraid to use it when describing like a rash, for example. Why it's also important to mention things around asymmetry, color, border, and things like that is that it's used in this 7-point checklist. So the 7-point checklist is you can kind of use it as a referral guideline of when you need to 2-week wait pathway someone. So the 7-point checklist talks about these major features which score 2 points, that being change in size, irregular shape, and irregular color. And 1 point for things around the diameter, if it's inflamed, if it's oozing, or if it's changing sensation. And in a GP setting, what they would note is that if you have 3 or more points, you would want to refer for under a 2-week wait under the cancer pathway to dermatology. Because things like changing in size of a lesion and irregular shape, irregular colors, those are all quite indicative of malignant lesions, and you would want to refer them under a 2-week wait. With melanomas, you're of course going to want to do a biopsy. And Breslow's thickness, so I mentioned that previously. So Breslow's thickness is talking about the how much has that lesion invaded into the skin, and you would obviously only know that after you do a biopsy. And it is the single most important factor in determining the prognosis of an individual, because if it is above 1 millimeter, they say it's quite worrying in terms of it's quite invaded, say that lesion is invaded quite deeply, in which case you would want to also consider doing a sentinel node biopsy to see whether that melanoma has metastasized already. Now, the management of the melanoma is you're going to want to excise it. And narrow versus wide is referring to the excision margins. What that essentially means is how much of that lesion are you going to excise around. If you have a lesion that has a high Breslow's thickness, you would tend to go towards a wide excision margin. So you would want to excise more out of that lesion than something which is less invaded. And again, just to highlight the when to refer. So basal cell carcinomas, you want to consider routine referrals, and you might want to, again, refer under a 2-week wait pathway if there's anything concerning about that lesion to you. Say if it start looking like it's changing in its size, if it's looking like it's got a regular color to it. So things that is mentioned under the 7-point checklist. And 2-week wait, again, anything that is suspicious of a melanoma, skin lesions which have got 3 or more on the 7-point checklist, anything that's suggested of a nodular melanoma, and anything suggested of a squamous cell carcinoma. These are all from the NICE guidelines, by the way. Just wanted to do a sort of shout out to seborrheic keratosis, because you might see a lot of people who have this. And these are completely benign. And it can be, sometimes it can be quite difficult to differentiate it from a malignant melanoma. But the thing is with seborrheic keratosis is, number one, it kind of has this stuck on, the typical terminology that they will use is this stuck on, warty, greasy like appearance. And it will tend to be quite uniform in terms of its color. So you wouldn't usually get, you know, loads of multicolored lesions. It would be quite uniform in color and its shape. When things start becoming less uniform, that's when you want to consider melanomas. Right, next SBA. A 3-month-old infant is brought for evaluation of his scalp scaling. How would you treat his scalp condition initially? So I'll give you guys a bit of time for that. Okay, let's go through it. I'm going to stop the poll. So yes, you would want to use olive oil. So what this skin condition is, poor child, they've got infantile seborrheic dermatitis. And what this is what this image is called a cradle cap. So it's this kind of greasy scaling of the scalp. And with kids, you just want to give them a bit of olive oil, basically. So what seborrheic dermatitis is it's caused by a fungal infection called Malassezia furfur, which is quite a funky name. And what you get in adults in particular, you get this essentially what looks like dandruff, this sort of plaque. They will look like plaque-like lesions that's quite scaly. And in kids, as I mentioned, you get this cradle cap, but you might also get what they call sort of spreading over throughout their body. So you might get sort of salmon-like patches across their body that's suggestive of seborrheic dermatitis. The thing to note with it actually is associated with HIV and Parkinson's. And if you look at the indicated conditions for when to test for HIV, seborrheic dermatitis comes under it depending on its severity. So that's something to note. And you can get complications from it. So you can get things like otitis externa, you can get blepharitis, which is essentially irritation or inflammation of your eyelids, essentially because of the seborrheic dermatitis spreading. In children, you want to give olive oil. In adults, you can consider over-the-counter preparations, things like Head and Shoulders, Neutrogena tea gel, which has tar in it, which is meant to be helpful. And if that doesn't work, you can consider prescriptions like topical antifungals, things like ketoconazole shampoo. That can also be quite useful. SBA 3. I actually just lost the whole thing. Bear with me, guys. I'm going to open the bowl now. Yeah, you should be able to answer the question. So a 28-year-old woman comes to the hospital because of recurrent and progressive itchy dry lesions on his arm. He is a known asthmatic. Which of the following is the most likely diagnosis? Okay, I'm going to stop the poll. So what this is we're referring to is atopic dermatitis. So just to mention, Eczema or dermatitis, they're basically meaning the same thing, is a umbrella term describing a group of inflammatory conditions. And you get different types of eczema or dermatitis. Atopic dermatitis is essentially the most common, and it's what we, or in the public, will typically refer to as just being your bog standard eczema. Now, the other forms of eczema or dermatitis, you have contact dermatitis. So that's kind of, it means what it says in the name. So it's due to irritation with contact to certain things like metals, and it's a kind of an allergic reaction. And you would see that in the history of an individual. So they would mention, you know, when I touch XYZ, or I tend to notice this rash in a particular area of my skin, and it can be quite localized. You have I can't say that word, osteostotic, I can't say the word, but what you see in B, and what that is referring to is you tend to find this kind of dermatitis in elderly individuals. So this is essentially when the sebaceous glands start aging, and essentially it causes drying of their skin. Atopic dermatitis is the most common form of dermatitis, as I mentioned, and it's IgE related, meaning it's an antibody antigen mediated reaction. And I'm going to talk about that a little bit later, because that's why being asthmatic is relevant in this situation. Dyshidrotic eczema, or Pomphylix eczema is another terminology that they can use for it, is essentially a type of eczema that we don't really know what happens, but what you would find in the history of someone who has this eczema is this kind of itchy burning sensation, often in their palms of their hands, or their soles, and it will be quite red, inflamed and itchy, but we don't know why it happens. And nummular eczema, also known as a discoid eczema, is a form of eczema which you will find well demarcated round or ovule plaques that again tend to be red and quite itchy. Now, atopic eczema, as I mentioned, is the most common type of eczema. It's IgE related, meaning antibody mediated allergic reaction. In terms of the pathophysiology of it, so what tends to happen is your skin barrier tends to be eroded or reduced. So the sort of protective skin barrier, the lipid layer in your skin, tends to be eroded or reduced in people who have eczema, which means that their skin is exposed to the irritants of the world, and it tends to lead them to have more drier skin. And this also somehow initiates a kind of immune reaction, which is when your IgE sort of antibodies step in. And the reason why that's important, particularly, is in when what you will find with people who have eczema is they will often have other comorbidities, things like asthma. They might have a history of allergies to things. They might have hay fever. And it's really important when you're asking within a history of an individual, asking about whether they have these things like asthma, if they've got allergies, and if they have a family history. So does anyone in their family, their mom, their dad, do they have different allergies? Do they have hay fever? Because it can give you a better idea of the eczema that they have. What you tend to find again in eczema is you tend to find in the extensor surfaces of an individual. So sort of the back of your elbows. Let me say that again. In younger children, you tend to find it in your extensor surfaces. But in older children, you tend to find it in more your flexor surfaces. So that's your inside of your elbows. And I'm going to mention treatment a little bit later on in the next slide, but just to show you the picture of the distribution of eczema. So it varies, it tends to vary across the different age groups, but in kids it tends to be, in younger infants it tends to be actually more in the extensor area. You can sometimes get these lesions around the nappy area, and in your childhood it tends to be found in your flexor surfaces. Now, treatment with eczema is there's a few things that you can do. So number one, you want to give lifestyle advice, things like being careful about what kind of detergents you use, wearing cotton clothing can be quite helpful. You want to give them lots of emollients. So emollients I kind of just described as being really thick moisturizers, and you want to use that as much as you want. You don't need to hold back in the amount of emollients that you use. Lather them up, basically. And alongside emollients, if lifestyle factors and emollients aren't working, that is when you can introduce steroids. Now, it's really important, if someone is using emollients and steroids together, you want to first advise them to use your emollient first, wait 30 minutes, and then apply your steroid. And there are different strengths of steroids. And in my med school, we were made to kind of memorize the generic brand names, because it can also be quite useful when describing to patients. And there's a little mnemonic that you can use to try to remember the strength of the steroids. But with eczema, you tend to start mild. And you would only really use it for a 7-day to 14-day max period with steroids before you stop using it. You don't want to use steroids for too long with eczema. And an important thing when you are counseling someone with using topical steroids is there's this thing called a fingertip rule. So what that means is 1 fingertip of steroids on your hand should cover the surface area of twice the size of an adult's hand. So that's how little of steroid that you need, because with steroids, there are going to be side effects, things like hypopigmentation, things like irritation. And if you use it in a sort of prolonged, and particularly with higher strengths, you can start getting the systemic side effects with steroids. So you want to make sure that you are counseling patients when using topical steroids properly. Moving on to SBA 4. Let me open the poll. A 40-year-old man presents to his GP with a raised, well-demarcated, red, scaly, patchy rashes on his elbows and knees. He tells you the lesions have come on slowly over the past few months and they are itchy but not painful. His past medical history includes asthma, bipolar disorder, gout, and hypertension. Which of the following medications may trigger exacerbations in his condition? So I'll give you guys a minute. Okay, so the answer is lithium. I thought I'd put asthma in then to throw people based on what we just described with eczema. But what this skin condition is describing is psoriasis. So psoriasis is quite an interesting skin condition. It can present in your sort of earlier stages of life, between sort of I think they say around 16 years old, 16 to in your early 20s. And it can also present quite later in life when you're 50s and in your 60s. And the I guess the pathophysiology behind it is what happens in psoriasis is that the surface of your skin cells multiply quite rapidly, and it ends up with your skin cells sort of growing on top of each other, which is why you get these plaque-like lesions in psoriasis, because it's essentially all of these skin cells just building on top of one another, and they're not cleared up, and that also triggers an immune response. And with psoriasis, again, as I mentioned, the description that you will get is these red, scaly-like plaques with well-defined edges, and they will often have these sort of silvery scales, and you tend to find it in your more extensive surfaces. So say, for example, in the back of your elbows. The thing with psoriasis is that you do get systemic symptoms as well. So you are at increased risk of cardiovascular disease. You might have heard of something called psoriatic arthritis. And you get these, you might, very much further along the line, get these nail changes. So what you what you see here is this pitting on the nail. You might get oncholysis, which is essentially the nail bed separating, or the nail, sorry, separating from its nail bed. You might get ridging across the nail too. And you might get what is seen here as a hyperkeratosis, so the thickening of the nail at the end. And you would tend to get this again very much down the line with uncontrolled psoriasis. With exacerbating factors, so that's what the previous SBA was mentioning. So lithium will exacerbate your psoriasis, ACE inhibitors, antimalarials like hydroxychloroquine, beta blockers, steroids as well, or sorry, not steroids, steroid withdrawal can exacerbate psoriasis. I is mentioning infliximab or interferons, and NSAIDs as well can also exacerbate your psoriasis. And lifestyle things like stress as too, again, can be quite a big thing in exacerbating psoriasis. Now, the management for it is quite similar to eczema in the sense that, again, lifestyle factors, but also using lots of emollients can help with reducing itchiness and reducing the itchiness associated with psoriasis. But the thing with psoriasis is that your steroid usage is more intense. So you tend to go for more potent steroids over, so that's just my mom calling me, let me decline that. With psoriasis, you tend to get more, you would tend to want to use more stronger strengths of steroids, and you use it for longer periods. So with psoriasis, you would want to start off with using, like I said, your lifestyle and your emollients, and you do want to give them steroids. You don't want to wait to see those if those emollients would work. And you would use steroids alongside vitamin D. And I think vitamin D is used because it helps with reducing cell production, something along those lines. I don't know the exact mechanism behind why topical vitamin D is useful with psoriasis, but it's something to do around cell production. And you want to use those topical steroids for 4 weeks over 7 days that you would do in eczema. So use those topical steroids alongside vitamin D for 4 weeks, and then you have a 4-week break. And if that doesn't work, there's sort of an escalation that you can use. You can use stronger steroids, you can just use vitamin D, and then you can start going into using things like phototherapy. And you might want to, if that still doesn't work, start using systemic therapy, so your biologics, things like infliximab. And again, that is very much down the line. I think this is our last SBA. So a 70-year-old male presents to the GP regarding his acne. He has been treated with a topical retinoid and a topical antibiotic. What is the next most appropriate step in management? So I'll give you guys around 30 seconds to answer this one. Okay. So we know what the skin condition is. It's acne. What we need to know is what is the ladder in terms of treatment for acne. And in this case, this guy, he started off with a topical retinoid and a topical antibiotic. That wasn't working. So what are you going to do next? To know if you're going to give oral antibiotics, I don't think you wouldn't really use topical antibiotics alongside with it, but you would want to continue on using a topical retinoid. With acne in particular, it's quite important that you don't really take any form of antibiotic on its own. So if you're going to give someone an oral antibiotic, you're going to want to give them something topical alongside it, either a topical retinoid or a topical benzoyl peroxide as well. So just a bit of pathophysiology with acne. So what you get is these things called comedones, which is essentially clogged up hair follicles. What happens is you get these hair follicles, they get clogged up with debris, sebum, things like that, and it ends up blocking this hair follicle, and that's when you get a comedone. And a comedone can be an open one, which is referring to blackheads, or it could be closed, which is referring to whiteheads. You get different severities of acne, so mild, moderate, severe. Mild, you tend to get fewer of these open and closed comedones. With moderate, it tends to step up into being more numerous in terms of the number of comedones that you have. And with severe, you tend to see really inflamed lesions, and you might start getting more permanent scarring as well when you start getting into the severe types of acne. And really nowadays, we should really be preventing people from getting to this stage, or particularly preventing people from getting to the point of scarring, because scarring can be permanent or very, very difficult actually to remove. And scarring is not the same as hyperpigmentation that you get with acne. I'm talking about really deep pitting scarring that people can get with acne. So it's really important thing to treat. So lifestyle advice. So things like diet and stuff like that. I know people will say, sort of from their own personal experience, oh, if I eat healthy, my skin looks great. But I think actually in the literature, it is things like, for example, cutting down on chocolate and stuff like that. That's not really appropriate or not really backed up by the evidence that we have in the literature, although it might be backed up by your own sort of personal experiences. But lifestyle advice, I think, mean things like, for example, making sure you clean your makeup brushes, thinking about not over washing your face, because that can actually worsen your acne. Being gentle to your skin and promoting or maintaining your skin barrier by ensuring there's plenty of hydration of your skin is really important in acne. Now, in terms of the treatment, so again, there's lots of different stuff that you can have now. So you might want to start with something more topical, things like topical benzoyl peroxide. You might want to use topical retinoids. If that doesn't work, you can add on topical antibiotics. And if that doesn't work, you can start going down the more oral route, so adding on oral antibiotics. And the last stage is your oral isotretinoin, and that you would need to take under specialist supervision. Because there are significant side effects with taking oral retinoids. Things like depression is the big one. There's a huge risk if you're pregnant, it can be incredibly harmful to the fetus. So with oral retinoids, there's more of a stricter surveillance that you need to be under. Now, with all of these topicals, particularly topical benzoyl peroxide and topical retinoids, it's important that you're counseling patients. Things like being aware that it can, particularly with topical benzoyl peroxide, it can lead to hypopigmentation or bleaching of the skin. And it's really important that you're wearing sunscreen whenever you are on these medications. And it can also be quite irritating, and it can take a bit of a period of adjustment for people when they start using these topicals. But there is a really nice ladder or sort of progression of a ladder in terms of treatment wise. And I would advise looking at the NICE guidelines, because I think they explain it quite nicely in terms of the steps up that you can use for people who have acne. Oh, sorry, this is the last SBA. 40-year-old woman presents with facial redness and small prominent blood vessels on her face. She is often found blushing. On physical examination, there are no comedones. Her rash does not spare the nasolabial folds. She is otherwise well. Given the history and examination findings, what is the likely diagnosis? I'll give you guys 30 seconds for this. Okay, so I'll stop it there. So what this is referring to is acne rosacea, which is a type of chronic skin condition which affects the blood vessels in your skin. And you typically tend to see this in more fair individuals, although you can definitely see in individuals with darker skin tones. The referral to the nasolabial folds is referring to a malar rash that you might see in lupus, or you might see in certain dermatitis or dermatomyositis. I'm going to talk about the systemic presentations of skin conditions in my next in my next session on dermatology. But with malar rashes that you see in lupus, you will get this sort of sparing of the nasolabial fold. But with acne rosacea, you won't get that sparing. And what you tend to find with acne rosacea is you get this flushing of the skin, you will get this telangiectasia, so it's kind of like the widening of the blood vessels in your skin, and it will often be aggravated by sun exposure. And the thing with acne rosacea is it can lead to certain complications. So the image that you see on this slide is kind of the step-by-step of how it can become more severe and some of the complications. So you start off with this kind of redness around your skin area. It might then step up into these pustules or vesicles, but you won't have comedones. And that's why in that SBA, it was important to note that there was no comedones, because when you see comedones, that's acne. That's not acne rosacea. And then this can further becoming complicated when your skin starts getting hardened. And so what you see here is rhinophyma, which is sort of this, your skin starts hardening. And then you can get further complications around your eyes. You can get blepharitis again, which is inflammation of your eyelids. So yeah, it can actually get quite severe. The management of it, so if it's just this kind of redness, you might want to try topical brimidine, a topical brimidine gel, which can help with, I think, reducing the dilation of the vessels. And if things start becoming escalated and you start getting these kind of complications, that's when you can start using antibiotics. I think you use doxycycline. You can use doxycycline or metronidazole, sorry, for these more severe cases of acne rosacea. Okay, so coming up in my next dermatology teaching, I'll be talking about cutaneous manifestations of systemic diseases. So things like looking at lupus and things like looking at other systemic diseases and how it can show up in your skin. I'll be looking at dermatological infections. I'll be going through some emergencies, and I will end with with a spotter. So I'll just throw a bunch of pictures and ask you guys to name what that condition is. Thank you very much for listening, and I hope you found this session useful, and it would be great if you could give me some feedback. But thanks guys, and enjoy the rest of your evening.
Thank you so much, Nazifa. If anyone has any questions, feel free to post them in the chat quickly, and if you're watching on YouTube, please do fill in the feedback as well. We keep the links open for quite a long time because we know a lot of you just watch online now, so please do fill it in even if you're watching on YouTube.